Today we are going to discuss burns. It is another very important topic for your exams and also for your practical life. One day or the other, you will have to deal a burn patient. So, first thing, what is a burn? Burn is a type of tissue injury which may involve the skin or deeper structures, and it is usually caused due to extremes of temperature. Other causes may include electricity, they may include chemicals or radiations or simply friction. It is a type of coagulative destruction, and any temperature, because thermal burns are the most common type of burns. So any temperature more than 48 degrees centigrade will usually lead to thermal damage, but the extent of that damage will be determined by first thing, the duration of the contact with that extreme temperature and how high that temperature was. Similarly, low temperatures, sub-zero temperatures will also lead to burns, and they may be discussed separately. We consider two things. First thing is the depth of the burn. Depending upon the thickness, we consider it. We categorize it as superficial burns, superficial partial thickness burns, deep partial thickness burns, or full thickness burns. The second thing we consider is the degree of burns, which we will discuss later on. If we start with the superficial burns, these involve only epidermis. These are type of the burns that we usually get if we accidentally pour hot water on our finger, or while working in the kitchen you get steam on your hand or your forearm. That is the type of burn you get. It involves only the epidermis. The involved area is red and dry, and it is quite painful. This type of burn usually heals within 3 to 5 days, and you don't really need to do anything for it. You just give analgesics, or sometimes you give topical antibiotics. If the burn goes a bit deeper, we call it superficial partial thickness burn. It will involve the epidermis and the upper layers of dermis, which we call the papillary dermis. These are characterized by erythemas and blisters. Capillaries return visible on blanching. Pain again is a very prominent feature, and it usually resolves in 48 to 72 hours. Healing will occur in about 2 weeks without any visible scarring. The treatment again is non-surgical. You don't really need to intervene. You just give antibiotics, topical analgesics, and the wound usually heals by itself. Both these types are extremely painful. Why is that? Because pain, if you remember your physiology, pain receptors are free nerve endings, and free nerve endings go all the way to the upper layers of the dermis. And in these two type of burns, those free nerve endings are being exposed. That is why these burns are very painful. Even the air from the fan will cause the patient to scream out in agony. If the burn goes even deeper, then we are dealing with a deep partial thickness burn. This involves damage to the deeper layers of dermis, the reticular dermis. The epidermis is usually lost, and now the deeper layers are damaged, so the nerve endings are also damaged, the capillaries are also damaged, so there is no blanching, sensations are reduced, and obviously it will take longer to heal. And when it does heal, because the deeper layers of dermis are responsible for regeneration of the upper layers and the epidermis, so these type of burns will not heal normally. They lead to hypertrophic scars, and they may also need debridement and eventually grafting. Full thickness burns are the extremes of burns. They are the burns which happen when a person is inflamed, caught in flames within a closed area, or things like that, or what you heard in what sometimes hear in the news कि जी कपड़ों को आग लग गई या इस तरह घर में आग लगी. So these are the type of burns which we see in those cases. Appearance varies because from the patient's look, from the normal skin up to charred black leathery skin. Whole of the dermis is destroyed. Even the deeper layers of the tissue are destroyed. There is no capillary refill. Blood vessels are destroyed, and there is no visible sensation, no sensations at all in these patients. As you can see in this picture, this black area, this isn't normal. This is also burnt, and this white area, this is also burnt. This is a deep burn involving almost the whole of this patient's body. these type of burns will require treatment. As the nerve endings are also destroyed, there is no pain. As I've discussed previously as well, pain at some points is a very good thing. In this condition, in deep burns, having no pain means the nerves are now destroyed. This is one of the indications of the depth of the burns, and it is usually not a good thing. The treatment will remove involvement of all the dead tissues. Repeated debridements are required, which will eventually lead the patient to multiple sessions of grafting as well. This picture shows the same patient after he has had a thorough burn wash. You can see all the dead skin has been removed, and now these areas will be observed in the next few days. As you can see over here, these are further deeper burns, and they will need to be debrided and eventually grafted. The common scenario that we see in our practice is a mixed thickness burn. Usually the superficial type of burns may occur in an isolated setting, like you may have a superficial burn, but deep burns usually do not occur independently. An area of deep burn is usually surrounded by an area of relatively milder degrees of burn. As you can see in this picture, this area is full thickness, and then as you move away from it, you get deep partial thickness, superficial partial thickness, and eventually at the margins you will have simple superficial burns. That is why we say these are mixed thickness burns, and as the variable depths of burn, so you have to involve multiple treatment techniques as well for these patients. The second thing we consider are the degrees of burns. Degrees are very much similar to the depth of the burn. As we say, there are four, when we consider the depth of the burn, we consider 4 categories. In degree of burn, we consider 3 categories: first degree, second degree, and third degree. But in this, we sometimes divide the second degree into second superficial degree and second deep degree. All of these are synonymous to first degree is synonymous to superficial burns, second degree superficial is synonymous to superficial partial thickness burn, second degree deep is synonymous to deep partial thickness burn, and third degree burns are the same as full thickness burns. So if we just compare these, so this is just a comparison between the degrees and the thickness of the burns. So what does the burn do to a person? As we said, it's coagulative destruction of the skin and deeper tissues, but other things may also be involved, and the most important of these are your respiratory airways. A burn may damage your lungs and your respiratory passages. How does it happen? It happens in multiple ways. First of all is a physical burn injury. Upper airways are damaged by the hot air being breathed in, and lower airways are then further damaged if you breathe in hot steam. Then the second important factor to be considered here is metabolic poisoning. Carbon monoxide is produced when there is a burn in a closed environment, like inside a room or inside a car. So carbon monoxide will combine with hemoglobin to form carboxyhemoglobin, which leads to disturbance of the oxygenation cycle. And then again there is another thing, hydrogen cyanide, that is very poisonous. It's produced when there is burn in enclosed areas, especially if plastic is being burnt. Next thing, inhalational injuries caused by minute particles which you breathe in when you're breathing in thick smoke. Those particles may damage your lung. And finally, when the burn involves the chest, there may be difficulty in chest movements. Movements may be restricted either due to a eschar or due to pain. I must discuss here what is an eschar. Eschar is a special type of scar that usually forms in burn tissues when there is coagulation of the skin and deeper layers. It's different from the routine scars that we see in different injuries, and these eschars produce difficulty in muscle movements. We will discuss this further. Next thing, there is appreciable fluid loss. Any burn more than 15% body surface area will require fluid replacement. Hemoglobin urea due to tissue destruction, and which eventually leads to renal damage. Obviously, energy requirements are increased, leading to increased metabolic rates. Overall immune system is damaged because the skin is your first protective layer against any invading microorganism. In burns, the skin is lost, so you're exposed to external pathogens as well. And changes to the intestine. uh, Burn is a cause of major physiological stress for the body, and whenever body experiences a physiological stress, it tries to save vital organs at the expense of certain other organs. For example, the blood supply to the kidneys and the intestine is also reduced. This leads to ischemic injury to the gut mucosa, and it may be so severe that the gut may become gangrenous. So what do? If we encounter a patient who has been burnt, first thing you need to do is stop the burning process. How do you do it? You cover the burnt person with any sheet of cloth that you have. There's a statement said stop, drop, wrap, and roll. So the burnt person should just stop moving. He or she should drop down to the ground. If there is a sheet of cloth, that should be wrapped, and then the person is asked to roll on the ground to smother the fire. And once the fire has been put out, you check for other injuries other than the burnt area injuries. Next step, you have to cool down the burn wound, and the easiest and the most commonly done way is just wash the burnt area. And this is a misconception in our population. People come to us in outdoors and post-operative patients, they come to us and say कि जी डॉक्टर साहब जख्म पे पानी तो नहीं पड़ जाएगा. This is a misconception. We need to wash the burns and other wounds with clean running water, ample amount of clean running water. You elevate the patient into a sitting position, which makes it easier for them to breathe, and you elevate the burnt limb. Again, this is an attempt to highlight some of the misconceptions. We do not put on any oils, we do not put on toothpaste or any egg white or any such thing on the burnt area. They're useless. You just wash the burnt area, you use topical antibiotic ointments, may use some cool compressors. You may need to take antibiotics or analgesics orally, and aloe vera juices or aloe vera gel may produce a soothing effect in superficial burns. So how do you proceed once you've put out the fire, once you've done the initial management? Then you proceed with ATLS protocols, airway, breathing, circulation. It's very imperative that you identify any injuries to the airways or the breathing mechanisms, because they have to be dealt with immediately. Do not remove clothing stuck to the skin, because if you try to remove this clothing, you may remove the burnt skin, exposing the deeper layers, which may then become infected. Do not puncture blisters. Blisters are nature's way of isolating the burnt area. They are nature's way of dressing the wound. So you do not puncture the blisters till the time the patient has reached emergency of the hospital, where they can be punctured and debrided in a very sterile manner. And do not forget to remove the jewelry, because one thing, this jewelry will become hot and it will increase the depth of the burn. Second thing, once the limb starts to become edematous, this jewelry may become stuck and it may cause gangrene of the distal area. So you remove the jewelry as soon as possible. Jewelry and any other metallic items on the person's body. The next important thing is you need to assess the extent of the burn. How you do that? We use the commonly used formula is Wallace rule of 9. We divide different parts of the body into segments, and we just calculate using a simple formula of 9. We use a table of 9. Like upper limbs, both front and back combined is 9%, and lower limbs are 9% on the front of lower limbs, 9% on the back of lower limbs. Head and neck region combined is 9%. Front of chest is 9%, back of chest is 9%. Similarly, front of abdomen is 9% and back of abdomen is 9%. All of this combined makes about 99%, and the remaining 1% is the perineum. But as may be pointed out, burn doesn't follow any anatomical landmarks. It may involve any area, it may be in patches. So another way to calculate percent BSA, we have used the word BSA. BSA stands for body surface area. The patient's palm of hand is equal to 1% BSA. So if it's a patchy distribution of burn, then you can just take a measure using the patient's palm. There's another formula, the Lund-Bruder chart, but that is not very commonly used. So the patient has now reached an emergency and you've done the ATLS. Now you're dealing with the burn specifically. So what do? First thing, you wash the burnt area. This will relieve the pain, this will prevent the burn becoming deeper, and it will wash out all the debris and the dead tissue as well. Secondly, you give analgesics and antibiotics. These may be in the form of injectable medicines or topical treatments. And then you dress the wound. There are basically two schools of thought when we are dealing with burn wounds. One school of thought says that you should always dress the wound, it prevents infection. The second school of thought says that you leave the wound open and you then let it heal. But if you want to leave the wound open, you need to provide a complete aseptic environment and you keep the patient. In our setup, it's not usually possible to do that, so we commonly dress the wounds. Things to keep in mind, you do not apply cold to more than 20% of an adult's body surface, because if you do that, you will risk hypothermia, and hypothermia is something that is very easily missed and it leads to death in especially in children. And you do not apply any greasy ointments or butter or cream or sprays or home remedies. They will only prevent you from treating the wound. Once you've assessed the depth of the wound, you've assessed this extent of the burn, now you have to calculate the fluid requirement for this patient. And how do you do that? First, you need to know when the burn happened, what's the weight of the patient, and how much is the extent of the burn. We use the Parkland formula. It's a very simple formula. You just multiply four things. First is the body surface area, the percentage of the burn. Second is the weight, and then 4. This 4 is a constant. So if it's a person who has burnt his right arm, let's say for example, and his weight is 70 kgs, so it will be 9 multiplied by 70 multiplied by 4. Okay, it's very simple to calculate. Once you've calculated it, you divide it into two parts. The first part has to be given in the first 8 hours after burn, and the second part has to be given in the remaining 16 hours. This is fluid calculation for first 24 hours. If the burn is older than 24 hours, then you don't need to do that. Then you just need to give replacement fluids like you calculate for any other patient for daily requirements. Which fluids do you want to give? You want to give crystalloids, you want to give ringolectate, you want to give saline, you want to give, if you don't have those, you will give this plevolite. You don't usually give 5% or 25% or 10%, they're useless fluids. Secondly, colloids. Colloids, for example, we give this Hemocel. Colloids are usually not recommended in the first 24 hours because at that time capillary permeability is very much increased. These large molecules will pass through the capillaries into the interstitial spaces, and then they will pull water towards them, causing interstitial edema. Water will not stay in the intravascular compartment, it will go out of those intravascular compartment into the interstitium, causing problem in hydration. The key to monitor resuscitation is urine output. If your patient has 0.5 to 1 ml per kg per hour urine output, that means he's adequately hydrated. If it is less than that, you still need to give more fluids. Not every burn needs injectable treatment, or not every burn needs to be admitted to the hospital. So we have developed a criteria. This is an internationally recognized criteria. If a child is having 10% or more body surface area burnt, or an adult having more than 15%, then you need to admit. If there are inhalational burns, again you need to admit. If there are special burns, for example chemical burns, electrical burns, radiational burns, then you need to admit. If the burn has involved specific areas of the body, for example head and neck, perineum, hands, eyes, then you need to admit and you need to give injectable treatment. This injectable treatment will include fluids, antibiotics, analgesics, tetanus prophylaxis, omeprazole for gastric cover, and other similar things. So, where does surgery come into all this? When we are dealing with a burn patient, we usually don't need to perform any immediate surgeries in cases of superficial and superficial partial thickness burns. We just need to clean them once and then apply ointments. They will usually recover. But when we are talking about full thickness burns or burns involving more than 40 or 50% body surface area, then we need to consider other things as well. For example, if the head and neck is involved, the patient is having difficulty breathing due to swelling in the face or in the of the swollen tongue, or difficulty due to damage to the respiratory passages, you may need to manage a surgical airway. You may need to do a tracheostomy. Secondly, if the burn is extensive and you cannot find an IV access, you may need to do a venous cut down in the lower limbs, or you may even need to pass a central line through the subclavian or the internal jugular. Then deep partial thickness burns or full thickness burns will, in second stage of treatment, on the second day or usually on the first day, they will require debridements. And eschar, as we discussed earlier, they are a special type of wound because burn coagulates the tissues. It makes a kind of a hard scar in the initial phases. These scar will cause problem with the blood supply. So what we do is, as you see in this picture above, we need to cut open this scar. Okay, we have predefined areas where we need to put these incisions, and we cut these scars open to relieve the pressure on the underlying tissues so that the blood supply may continue. The distal tissues may not become gangrenous. As you see here, this is escharotomy, and these are eschars, these are fasciotomies on the hand as well. So escharotomy is done to relieve the eschar, and fasciotomies are done to relieve pressure on the underlying compartments, again to prevent gangrene. And eventually deep burns or deep partial thickness, full thickness burns will also require grafting. As you can see in this picture, this is a deep partial thickness burn, and this was the burn initially, then it has been debrided. When you have this healthy red look, then you perform grafting, and this is eventually a healed wound. There are some other aspects to management of a burn patient other than what have already been discussed. Patient requires analgesia. Patient requires analgesia in adequate amount, even post-operatively, even after the management, because it may lead to permanent nerve damage. So you need to calculate the patient's requirement and what you need to give him. Secondly, burn, as I said earlier, is a state of high metabolic stress. You need to keep the patient's nutrition adequate. The patient will require excess calories. The patient will require excess proteins. So you need to calculate that and you need to supplement that. Infection, again, as I said earlier, skin is your first barrier against infection, and now in burns that skin is gone. So you need to monitor, and if you find there are infections, then you need to control those infections. Nursing care, simple things as changing posture in the bed, simple things as keeping a proper hygiene, proper nails, and all that may make a very big difference in management of a burn patient. Physiotherapy plays its important role in post-operative period when we are trying to rehabilitate a burn patient, when we are trying to teach him to walk again, when we are trying to teach him to work again. After skin grafting, when the patient has been stiff for months and then the joints are also stiff, the patient needs to move again, so he'll require the help of a very good physiotherapist. And sadly, a very commonly missed aspect of burn patient in our community, a psychological support group is very necessary, especially for females who have had burns to the face. They will require psychological support, they will require social support, So you need to give them an environment where they feel secure and where they feel that they can get back to their normal routine. So this was all about burns. Inshallah, see you in the next lecture. Thank you.